first question, education and training in Slovenia in the field of geriatric medicine. On undergraduate level, we have 2 medical schools. In both schools, geriatric is taught, although in medical faculty in Ljubljana, it is taught only a few hours lectures. But there is a rehaul of curriculum, and we expect that there will be much more space and time for geriatric medicine in Ljubljana. Another medical school of Maribor, it's individual subject in 5th year, consists of 15 hours of lectures, 15 hours of seminar, and it's awarded by 2 ECTS points, and it's as an elective subject of choice in 5th year or 6th year, with 5 lectures, 40 hours of seminar, and 45 hours of individual work, awarded with 3 ECTS points. As a postgraduate, there is a learning module only in family practice specialization. We have yearly event for interested public in the field of geriatric medicine. And there is ongoing discussion, should geriatric medicine be a specialization or just postgraduate qualification that could be awarded to internists and family practitioners. I have to add that there is lack of, we have very centralized healthcare system, public, and so public employers are not really keen that there will be another specialization among many others that are there already. How is preoperative risk assessed? Our primary care physicians, family practitioners are gatekeepers, and they are supposed to keep the gate very closed. So they are not allowed to do much more than this assessment, which is laboratory assessment and some ECG and things like this. And then they refer for preoperative assessment every patient before elective, of course, elective major surgery, to anesthesiology service in hospitals. This, I did a short survey in major hospitals in Slovenia for the case of this presentation. So this is, these are data for more than half of population of Slovenia. And from about 50%, perhaps a little bit less, to all the patients before major surgery are assessed 2 to 4 weeks ahead. All patients are assessed in specialized orthopedic hospital, which are very elective, and less than 50% are, this is really funny, less than 50% of patients are assessed in my university medical hospital. So there is wide heterogeneity in evaluation, beside history, lab testing, things like this, some functional tests. They assess ASA score and Euro score for cardiothoracic surgery, and some of them use also some specific risk assessment like child poo and NIHA score. I don't know how they implement, how this translates to risk in operation, but they use this as well. And some really are started to use NSQIP surgical risk calculator, which has module for elderly as well. But most of the time they rely on gut feeling. At the end they say, well, my gut feeling is it will work or it will work not. This is how they say. And some anesthesiologists perceive poor cooperation with family practitioners as an obstacle for good preparation of the patient. There is often suboptimal information exchange between family practitioners and anesthesiologists. We have no electronic healthcare record, so if the patient is not very young and healthy, they would need to carry on with them very huge files of history, and they are not doing this. So anesthesiologists they don't have insight to all of their history. And some anesthesiologists would see an opportunity if there would be some special service developed where patient would get preoperative evaluation, risk assessment, and prehabilitation before refer to surgery. Assessment on functional status and frailty. In family practice, there is no screening for frailty. There is no systematic assessment on functional status. They do cooperate with district nurses, and district nurses do report that some patients are not doing fine, that they have some disabilities or things like this. But this is not part of medical notes in primary care. They are aware of their problem, but they are really frustrated with work overload because they have to see at least 50 patients per day. And they are extremely, there's the last line, which is invisible here. They're also very frustrated by the fact that there is insufficient nursing, there are insufficient nursing services, physiotherapy services, and social services to work with. So even if you assess somebody, you have nobody to work with to improve the status of the individual. Another big group that encounters people with geriatric syndromes are gerontopsychiatrists. They don't screen for frailty. Inpatients are assessed with modified Katz index, but this is a part of nursing assessment, which is not communicated. Well, physicians are not interested for these results, so they are not communicated to each other. So functional status is only mentioned in discharge letter as general impression only, but they perceive this as an important thing. Okay. In neurology, again, false and cognition. No screening. Again, inpatients are assessed with modified Katz index as part of nursing assessment. And neurology says they very often use disease-specific tools for assessment of functional status of their patient. And they have very different attitude toward functional status assessment in different hospitals. In some hospitals, they say this is really important, but in other hospitals, particularly in University Medical Center in Maribor, they say, well, this is really not that much important. We have diseases to treat, not functional status to assess. As a conclusion, teaching in geriatric medicine in undergraduate level is improving. But postgraduate level and training needs demand from employers. So we need place for those to be trained to work. Preoperative assessment is, in majority of cases, assessed with clinical test evaluation history and ASA score. Functional status in elderly is most often assessed by nurses. And there is no systematic screening or assessment for frailty in Slovenia. Thank you very much.